Yes. Sorry?
Check your height and weight.
Again?
Has someone done it?
Yeah.
Fine.
Hello.
Hello, it's Katie.
Oh, hi,
How
Katie.
are you?
Yes,
Come through.
thank you.
All right, we're just in here.
Yeah.
Come
Thank you
through.
very much.
Oh, hello.
Hi, Carl. Please come and have a
Mr.
seat.
Bucur.
Hello.
Hello.
My name's
And
Dr.
you are?
Chandy.
Dr. Chandy,
Who
hello.
are you?
My name is
Francisco, he's like family.
He's
My best
family.
friend.
Please have a seat, Francisco.
Thank you very much. How are you,
Yes,
Carl?
yeah.
I'm good actually,
How have you
considering.
been
Thank
since
you.
the operation? Yeah, that healed well.
Yeah.
And
I feel everything. There was no inflammation or anything.
good.
It was really
That's
good.
good.
Great.
This is Dr. Chandy. He's our neuro-oncologist, and
Hi.
you
Nice to
probably
meet
met
you.
Katie or you talked to her.
Hello, yes.
Hey,
Hello.
I've met Ruth more than
yeah,
that.
we've spoken on the phone, but you, yeah, I don't think we've
Yeah.
actually met.
Yeah.
How is the arm? How is the
Well, I can move it, and considering I'm fine, I'm more than happy. But now that I'm almost off the steroids,
Yeah.
the seizures have come back,
Have they?
but not. So the duration is only 1 to 2 minutes,
Yeah.
but the frequency has gone from like 2 to 3 a week to 4 or 5 a day. But now I can manage it, you know, it goes like a minute and I can kind of sit it out and then it stops.
But your hand seemed a little bit.
I can move
it's
the
not
fingers.
As good as the last time I've seen you.
It has stayed this way. And when I have a seizure, I just try to, what I do is, I call it to prime them, to
Yeah.
prime the fingers or to prime the nerves. And then I do this again and it seems to be better. But during the seizure, which is always 1, 2 or 3 of these fingers,
Yeah.
it goes like 1 or 2 minutes. It doesn't take over the arm anymore, or the body, or my fainting or anything has never happened because of Capra, probably. So it is manageable. I'm not scared of them anymore. I can probably take a plane and sit it out, you know.
And how much steroids are you on now?
Well, today is, well, tomorrow will be the last day with 0.5.
Okay.
Tablet.
We did not have him on steroids before the surgery.
Right.
I didn't put him on steroids initially. He went home day 1, and then he felt a bit unwell, the arm worse, and we readmitted him.
Yes, I saw that.
Actually there were further seizures. So at that time, because we knew that there would be a glioma, we put him on steroids, tapering down with the expectation that he will still be on steroids as he comes here.
Sure.
And the second question, Carl, are you still on 1250 of Keppra?
Yes, 1250.
Yeah.
My last seizure, which I went to A&E for, they called Brighton and decided not to increase the Keppra because I was full on steroids very recently.
Yeah.
So that was about 10 days ago maybe.
Right.
And now that the frequency has increased, I'm not sure if that needs to change, but the duration is so manageable that I really don't know if you want to increase it or.
Just focal, maybe just to have a chat with the neurologist.
Yes, that's exactly what I thought. Yeah, we'll speak to one of our epilepsy specialists, seizure specialist doctors.
Okay.
Maybe probably add in something on top of the Capra.
Oh.
Because clearly they're not bothering you too much, but it's
Well, now-
it's better to get these things under control.
It is because the longest has been like hours, hasn't it? When we were in Crawley, that was really scary because it didn't stop. They actually admitted me in Red Hill. So, I mean, if it's minutes or even 20 minutes, I can do normal life until a certain extent, or other things come up. But if I don't know if it's going to last 2 or 6 hours, then it's completely different, of course.
Yeah.
Carl,
And also,
Yeah.
you get totally exhausted and neurologically.
Exactly. It's not good to leave
Yeah.
those things.
Carl, the reason you are here today is because we do have
Diagnosis.
the
Yes.
diagnosis.
Finally.
And you know, it's going to be a joint meeting, and I'm just going to do my bit, and then I'm going to leave you with Dr. Chandy and Katie. The result is back, and unfortunately, it shows that it is a glioblastoma.
So one of those GBM4
Yeah.
unoperable.
Well, it is inoperable because of the location. If we are to remove that, you will be paralyzed. And with that, obviously, you won't be able to have other treatment. The mainstay of treatment is going to be radio and chemotherapy.
And that means like life expectancy of 24 months or...
Well, statistically, yes, that's where we are looking at, yeah.
Right.
1 to 2 years.
1 to 2 years. Right.
But it really
And that's
depends.
and that's
It really
with
depends.
and that's with
That's
treatment.
That's with treatment.
That's
but
with
that
treatment.
is a statistic, and there is a broad range. So we will obviously hope and try to get you on the other side of that
Yeah.
range, but no, there's no guarantee.
No, of course. No, I think I've read somewhere that like 5% they live for years, but of course 95 they don't. So
That is
But there are certain aspects of positive to think about it. For instance, there was no necrosis. The feeling is that it was caught up relatively early. Yeah.
yeah.
But there are other aspects of the histology that are compatible with glioblastoma multiforme. So it is an incipient disease, but the reason we caught it up is because of that location that caused you that very specific. If it would have been in a different part, we would have been able to do more, but the likelihood is that you wouldn't have had the symptoms, and then you come with a much bigger
Exactly.
tumor.
Yeah.
So, Carl, with that, in all fairness, my job here has finished.
Is
and
there
to
any
leave you-
is there any evidence of GBM4s turning into 3s?
No.
So no, they don't change backwards. We don't have the final histology, and so
Oh, you don't?
We don't. So very rarely what looks like a GBM then turns out not to be, but we think that's unlikely. But we don't have the final histology. We just have the provisional histology.
Right. So
And the treatment is not going to change in
Oh.
your particular case. So
So-
that's why.
so even if it's not final, the treatment is definitely going to be the same.
That's why we wanted to bring you and
Yeah.
get it.
Well, if it comes back unexpectedly, the treatment will be finessed. But I think we know enough to start getting the ball rolling and
Right.
and talk to you about the treatment, which
Is it in London, or did you have to send it to Heidelberg? I think you said.
No, they don't.
Oh,
No,
okay.
they don't need to. They don't need to.
Okay.
Just some molecular stuff that they routinely do.
Right. Well, it's not like I wasn't expecting a bad outcome, so it's probably going to be a matter of managing the symptoms mainly, right?
Well, more than that, we also want you to do as well as possible.
Yeah,
We want
of
to
course.
keep this under control for as long as possible and keep you alive for as long as possible. And so that's what the rest of the conversation will be about, how the best way of doing that.
Would you be able to, in layman terms, kind of explain to me what or where things are going on that MRI?
Yes, Mr. Bucur is probably better than me for doing that. But
I think, shall I?
do you want to talk him through it?
Yeah. So, Carl, if you remember...
That's the last one post-biopsy, right?
Post-biopsy, and the reason we did that was just to have a confirmation that we have been in the right place. Yeah? So if you want to look at the scan before the surgery...
I think your Cyprus colleague told me you were able to remove more than just a tiny
yeah,
bit
but
of
it
stuff.
was not necessarily intentional as it had happened. So, look, this is before the operation.
Yeah.
So slices like that come from below. That's left. That's right. Yeah. So this is the left part of the brain,
Yeah,
and this is what we call the motor strip.
yeah,
So the part of the brain that controls the movement on the other side.
right.
And look at this, how it looks here.
Yeah, different.
Yeah. And this one, it starts here and then it's swollen up.
Yeah,
Yeah. And this is the sensory one that gives you the sensation. Yeah. And that is involved as well. So at the time of the surgery, yeah, we needed
That's
to...
after?
That's after. But a lot of the white bit here is because of the trauma of the surgery. Yeah. Because it's the swelling, the whiteness.
Right.
Yeah. I can show you other pictures, but I'll confuse you.
Okay.
So when we opened, and we needed to find a place where we can go in here. And because it's the motor strip, wherever we were touching, you know, it was stimulating your hand.
Yeah.
But we found a very tiny spot where there was no stimulation. Yeah. So we went into that, and what we do, we use electricity to go, so it would coagulate the vessels.
Yeah.
And as we have done that, because it was tumor there, it will come like a mushroom. So therefore, that's why I was able to do a little bit more, but not enough to say I did a debulking. So the aim of the operation, ultimately, it was just
It was just an Uber biopsy.
Yeah, an Uber biopsy. Yeah. Absolutely. So yeah, that's what we've done.
Okay.
And the idea was that if we don't find a place where we can go in, the idea was that I would probably go into this one.
Yeah.
But that would have been not that satisfactory, because it might give us a false sense of security. Do you remember we were talking about grade 2, grade 3? So some of these tumors, they've been lower grade and transformed. Some of them, they come as such from the onset.
Didn't you also mention? I think it would have broken up or degraded or kind of. If you had done something else, it would have, you know, collapsed in a way, or
No, for that to happen, I would need to take the whole thing out. Yeah. And that would have left you paralyzed.
yeah, no, I just had this. I thought you had said you didn't go further because it looked like it would have disintegrated in a way, in a negative way. So better
Yes.
leave it as is.
So that's right. So one of the things is that the surface is the cortex, where we immediately can find out what they are doing, and then under that, more like the dark bit here, is actually the white matter. So there are the neurons and there are the fibers, like strings. Yeah. And those ones, you know, you do not have the immediate. So I can take something but the neurophysiologist can't tell me straight away. So it is going to be a lag of about 30 seconds to a minute before they will tell me there is a problem.
Right.
But by that time it will be too late.
Yeah.
Yeah. So because we have the knowledge of the location where we were just a little bit more cautious
Yeah.
not to cause your weakness.
Good.
And even the fact that you have the focal seizure with the hand, the likelihood would have been that I would give you a hand weakness,
Yeah.
and it would have been limp, which, considering what you're doing and so on, it would have been, and dominancy of the hand, it would not have been a pleasant thing, even if it was a small stroke.
Yeah. Well, I can't write anymore,
Yeah.
and on the keyboard I'm already working with my left hand more, so I can only
About
do
the
certain things.
The mouse, because
The
you said
mouse,
you can't do the pad, but you can
sometimes,
do the mouse.
yes, sometimes, but I have to redo many things. But I was always a bit ambidextrous, so it may help for a time. So I'm not expecting to be off sick for now. I'll just try to keep on working and doing my best.
Alright.
So the treatment, is that something
Yes,
long
so
term?
I think Mr. Bucur needs to operate. Is
I'm
that
going
right?
to head off.
Good
'cause I
luck.
have thank you. So I'll leave you with Katie. I wish you all the
Nice
best.
to meet you, and
very nice to meet you.
thank
Well
you for
done.
helping me.
Well
Thank you
done.
for trying to
A
help me.
pleasure. I think all right. Bye for now.
Thank you.
Thank you.
So yes, let's talk about the treatment in detail, but before we do that, because I'm meeting you for the first time, can we go back to the beginning a little bit so I can get some more information from you?
Absolutely.
When did you first notice the problem with seizures and right-sided weakness?
It was on the 22nd of April. I had a major seizure at home,
Okay.
and I actually fainted and was there for about an hour.
No symptoms before that?
No.
No weight loss or anything?
Well,
like
I did have anxiety and stuff, and
Okay.
I did go to CBT sessions and all
Okay.
that, which could be related,
Okay.
but we will never know probably.
Okay.
Yeah.
And before that, apart from the anxiety, any other medical issues at all?
Well, 25 years ago, I had Lyme disease,
Lyme disease, okay.
and I did have a facial palsy, right and then left,
Okay.
but that's all.
25 years ago, yes. Any other medical problems at all?
Well, the appendix,
Yep.
cataracts. I have 2 implants.
Okay. And apart from the Keppra and the dexamethasone, are you taking any medication at the moment? I think you are.
Yes.
And I've got a list on the computer actually.
I'm taking
Atorvastatin.
yes, and escitalopram, so antidepressant,
Yeah.
diazepam and lorazepam. I have been on steroids, well, tomorrow will be the last day,
Yeah.
unless you reissue something.
We'll talk about that later. And you're taking omeprazole and levothyroxine, so you're hypothyroidism.
Yeah, but it is going down because I've lost a lot of weight.
Okay.
Last year I had atrial fibrillation in June,
Okay.
so the doctor said you just have to lose weight, and I did.
I see.
I've lost 32 kilos,
I see.
and since then those measurements from the thyroid have also improved. So my GP has been reducing the level.
Are you allergic to anything?
No.
And who's at home with you?
I live by myself and have no family. I'm single. I have an office job. I can work from home.
Okay. No family anywhere in the
Well,
world?
I do have family,
but
but
not you're close to.
not in the UK. He's my best friend.
Yeah.
My mother is in Madrid. My brother is in Germany.
Are you close to them?
I am, but well, only if I mean. You mean if we have contact?
Sorry?
Do you mean if we have contact?
Yeah.
Yes, almost on a daily basis.
Yeah, okay.
Yes.
Okay. They know what's happening?
Yeah, absolutely. And on bad days, he's been staying at my place overnight, so that's an option. He lives elsewhere,
Okay.
but that's an option.
Okay.
You know, if.
Sure.
But for now, I can do everything by myself, shower, everything.
Yeah, sure.
For now, let's
Sure.
see how that goes.
Sure.
It's a ground floor, so from the back I could even access without stairs.
Okay. Thank you. Do you smoke?
No,
Never smoked?
I have smoked a lot. I have been drinking a lot, but I stopped 5.5 years ago, cold turkey, and have never looked back.
Okay.
So I'm totally healthy in that regard.
Good. And what is the office work that you do?
It's account management. We have a German department at American Express,
Okay.
and I've been working 5 years here in Brighton, and
Yeah.
will be working the same job, same company, but from Madrid, starting July the 1st. It's just a change of contract, It's
Okay.
like an outsourcing thing.
Okay.
But I will be able to virtually continue doing that from here, if needed.
Okay. So if we're talking about several months of treatment,
Months,
yes. Is
No.
that treatment you want to do here or in Madrid?
well, if it's several months,
Yes.
and if we have a clear plan, I would switch.
Okay.
But if we said it's 4 to 6 weeks, and then let's see how
Okay.
a new MRI looks like in 4 to 5 months, then I would probably do it here.
Okay. Well, I will explain to you what the treatment involves, and you can make a decision as to where you want to do it. So do you currently have a date to move?
Yes.
What is that?
Well, my switching date, contract-wise, is
I'm
the
talking about living, when you're going to
No.
physically move.
no. I do actually have a place in Madrid and a place here.
I see. You've already got somewhere there.
Yeah. There's an
And-
overlap.
And you can work remotely.
I can work from
Okay.
either place.
Okay. Let me talk to you about the treatment then. The treatment involves, as Mr. Bucur said, a combination of radiotherapy and chemotherapy. 6 weeks of radiotherapy with daily chemotherapy tablets.
Good.
There's then a 4-week gap, and then chemotherapy tablets alone for up to 6 months.
Wow. Okay.
So,
That wouldn't imply necessarily having to be here, right? Or would I just
It
switch?
depends what you mean. If you're going to be in Spain for those 6 months, I can't treat you remotely.
Right.
If you're going to be based here with occasional trips to Madrid, that's doable. But you'll need to have regular scans, regular blood tests. I need to see you. So if you're living in Madrid, I can't treat you.
Would the treatment plan be as specific as for any high standard
Yes.
neurosurgeon
Yes, it's an
or
international-
oncologist
Yes.
to be able to adapt that to?
Yes.
Because I'm insured in Madrid, and
So one option would be that we do the radiotherapy here. When you finish the radiotherapy, you then have this 4-week gap, and then you could have the 6 months of chemotherapy in Madrid. And yes, it's an internationally recognised, standardised treatment
great.
that's been around for 15 years.
Wow.
So it's would be straight. I don't know where. I don't know the system in Madrid, but I can just say confidently it's an international regimen.
Yeah, absolutely. It's
that
very
would,
high
that
standard.
would be one option to do. We could do the radiotherapy and then the chemotherapy component, if you wanted to, could be done in Madrid. But I can't give you the treatment if you're living in Madrid and I'm not seeing you.
Yes, I understand. What is really the point of such an intense treatment plan if there is no prospect of positive
Yeah.
outcome
Yeah.
come 24 months in the future?
Yeah, so I understand the question, and the treatment, you might decide the treatment is something you don't want to do. What we know, however, or again talking statistically, is that the radiotherapy and the chemotherapy do keep things under control for significantly longer than without them. So you don't have to have any treatment, but probably you would live very much shorter than without any treatment at all. And it could be a small number of months.
But what kind of life would that be? I mean,
What would the quality of your life be if you had treatment? Is that what you're asking? Or
both really?
Or what would it be without the treatment?
Would the quality of life be as bad as or as good as? Let's say I do the treatment,
Yeah.
but with side effects, and I live 24 months. Great, but low quality of life. So let's say I don't do the treatment and I live half of those months with
A better quality of life.
Is that an option? Is that a possibility?
Yeah, it's a very good question, but in our experience this treatment is generally well tolerated, and I don't expect the side effects, the toxicity of the treatment to significantly make the time you have left worse.
And do the effects of the absence of a treatment, are they worse than the side effects of the treatment?
So what the treatment does is keep the tumour under control and therefore ultimately keep you well for longer than without the treatment. So the treatment keeps you alive and it keeps you well in a way that no treatment
Okay,
won't.
and no treatment would probably be painful, drive me crazy, whatever. That's my point.
No. At some point in the future, unfortunately, this tumour is going to limit your life, is going to kill you and make you unwell.
In which way?
Or
in many ways.
Normally what happens is your body slowly starts to shut down and eventually you become sleepy and don't wake up.
Right.
There's a possibility of things
I stop breathing.
Yeah. So the treatment won't change the way you die, but the hope is that it significantly delays that.
So even with the treatment, at some point, my body or
Eventually the treatment will stop working, or it won't work at all.
So my lungs will just stop.
Your brain will stop working properly.
My brain will stop and I wouldn't breathe anymore.
Yeah.
Even with treatment, at some point in the future.
The treatment delays that from happening, but it can't.
But not
it can't prevent it from happening.
But not much beyond 24 months, right?
So the regimen that we're talking about, the combination of radiotherapy and chemotherapy, has a median, patients who have the treatment have a median overall survival of around 1 to 2 years. And that's a median, which means half the patients do better and half the patients do worse. As you say, some patients do significantly better, And unfortunately, some patients do worse than that. What we can't do with certainty is place you
No.
on that range.
But let's
But as
say,
Mr. Bucur said, there are reasons to be hopeful that you would be one of the ones who does better.
because
than
of
the
my
average.
age.
Because of your age, because you're generally well, because the tumour has been caught relatively early.
So it could be 20 months.
It could be longer. I don't know how long you're going to live.
It's likely to be more than 1.5 years.
The average is about 1.5 years. I am hopeful.
In my case.
I am hopeful you'll do better than that, but I'm not going to.
No.
I can't, of course,
Of
promise
course,
you that.
I understand.
Is it realistic to hope that you'll do better than that? Yes. Can I guarantee it? Can I guarantee
Thank
it?
you.
No.
No, of course.
Yeah.
Right.
You don't have to make a decision today. Let me talk
Any
to
question?
Yes. I think it's too early for questions because I haven't really spoken to you yet about the
Well,
treatment.
he will.
Shall I
Yes.
explain? Why don't I explain what the treatment
Absolutely.
involves? So I'll split it into radiotherapy and then the chemotherapy. Radiotherapy, 6 weeks of treatment, daily treatment.
Starting.
It will start in about 3 or 4 weeks' time from the time you decide that you want it. There's a delay as we plan the treatment.
So I could even start in Madrid.
The first thing that needs to happen is that we need to get a planning CT scan. In this department, we make a plastic shell that's moulded to your head and neck. In this department, we then perform a CT scan. That will happen in the next week or so. Then when we've got that scan, we plan the radiotherapy and there's a 2 or 3 week delay.
It's because, of course, I need all this to have it properly documented in order to replicate that in Madrid.
Yes, sure.
So,
But as I said, this is any neuro-oncologist would...
yeah.
would-
But
would
by
know
when
this.
do you think I would have sufficient documentation
Of dates?
to this in Germany or Spain or wherever?
What do you mean by documentation?
Well, first of all, the diagnosis
The
and then the
final.
treatment plan.
So I can outline the treatment plan for you now. In terms of having the final diagnosis, that might take another week or so before that all comes back.
Right. So the treatment plan is pretty clear.
Assuming there are no surprises with the final diagnosis, there's a 1% or less chance that things will change, but unfortunately, we're confident that this is going to be what we think it is.
Yeah.
Enough to get the ball rolling. And if you wanted me, I would start to plan the treatment now, book the treatment now. If you want some time to think about things, then of course we can delay that process, but it will mean that treatment starts a little bit later. So very roughly, what we're talking about, and I can't give you precise dates, is a CT scan and shell in the radiotherapy department that would happen in the next 1 to 2 weeks. Then 6 weeks of radiotherapy. The radiotherapy is like having a scan. You don't feel anything. You wear the plastic shell, you lie on a bed, a bit like that, and if you could imagine a giant version of that lamp spinning around you and delivering radiotherapy, high dose radiation to the tumour, we do our best to keep the dose to the rest of your brain as low as possible.
So that's 6 weeks daily,
Monday to Friday.
Monday to Friday.
Side effects of the treatment involve the possibility of headaches, the possibility in the short term the seizures could get worse, possibly.
Would you increase? Oh no, you would
We're
combine
going-
the Keppra with something else, right?
We're going to address the seizures anyway, and so hopefully by the time you start, they'll be much better controlled.
Can we do that before starting?
Yes.
I mean, increase the Keppra for the time being.
We'll speak to our specialist colleague today. Is she around this
I'm
week?
not sure if she's around this week.
Yeah.
So
So in we'll get the ball rolling with that.
Yeah.
In the next few days, we'll get you started on some additional treatment.
Okay. Good.
The hair loss, possibility of headache, tiredness.
Yeah. Up to the point of not being able to work, maybe.
Many of our patients are able to work during treatment, but it's difficult. It's difficult because you'll be coming in each day. That's tiring.
Not really. I would be working from home. Oh, you mean the treatment, of course, yeah.
You're coming into hospital every day. There's hanging around. It's tiring. I'm not saying
Is
you
it-
can't work, but it's difficult. We normally advise patients to take the radiotherapy period off work if they can, but it's personal and it's up to you.
Is that coming in by bus or? Because I can't drive,
So
obviously.
of course you can't drive, but
Exactly.
yes, patients make their own way here. Where are you coming from?
Haywood's Heath.
Yeah, so
There's three, so 271, 272, 270.
Yeah.
And we'll go from hospital to hospital.
Oh.
And they're about a couple an hour.
So are you going to be too ill to take the bus? Probably not. We expect you to be well enough even towards the end of the treatment. The side effects build up. The first week you'll feel as well as you do now. Second week you'll feel a bit more tired. And by the end of the 6 weeks, significantly more tired. Patients often sleep for an hour or two in the middle of the day. But they're not in bed all day. They're not feeling terrible. They're not miserable. But they're tireder. And
Yeah.
sometimes they have things like headaches, and that's when we increase the steroids, which can be really effective.
Oh yes, that's another question I had because tomorrow I'm going to take the last half, so I would be
Yeah,
off.
we'll talk about that at the end if that's okay. Let's just talk about the treatment.
Yeah, sorry.
It's okay. So that's the radiotherapy.
Yeah.
In addition to the radiotherapy, we know that adding chemotherapy tablets that you take daily, 7 days a week for 6 weeks, makes the treatment more effective.
Right.
The radiotherapy is doing most of the work, but the chemotherapy adds a bit. The chemotherapy, again, is normally well tolerated. It can make you feel a bit sick, but we've got very good anti-sickness tablets for that. The other thing it can do is reduce your blood counts. That's not normally something you're aware of, but your white cell count can go down, which can make you more prone to infection, and your platelets can go down, which can make you more prone to bleeding. Normally that's something we worry about by just doing regular blood tests and keeping an eye on that, but if there's a problem, we'll let you know. We do ask all patients on chemotherapy to have a thermometer at home, and if there's any sign of infection, if you're feeling cold and shivery, if your temperature's up, you need to go to hospital 24/7 if you're unwell with it when you're on chemotherapy. Very rarely do we see our patients very unwell with infections, but there's a theoretical possibility of life-threatening complications. So we always ask, go early, get yourself checked out straight away, because the sooner we can get on top of an infection, the easier it is for us to keep you well.
Is it still a good option for me to go to the Haywood's Heath A&E, or should I, knowing what my case is, come down to Brighton rather than?
Yeah, we normally advise just go to your local A&E, so Haywood's Heath.
So that's still fine.
Yeah, that's still fine. That's still fine.
Okay.
There's then a 4-week gap where you stop both treatments. We then do a scan about 3 weeks later, an MRI scan, see where we are, and if all is well, 6 months of chemotherapy, same tablet, higher dose, but you only take it for 5 days. Then you don't take anything for the rest of the 4 weeks, and then you start again 4 weeks later, if that makes sense. So first 5 days of the month, you're taking the tablets, then you don't take anything else, come for a blood test, if all is well, we give you another 5 days, and then we continue that for up to 6 months, if you're well, if the scan's under control, and if your bloods are okay. So if you wanted to have the radiotherapy here, and then move to Madrid, that would be possible. Logistically tricky, I suspect, but possible.
But to me that sounds like kind of longer than expected
Yeah.
plan, which would probably last till the end of the year.
Right. Exactly.
So either I do it properly and then count on probably not leaving till the end of the year, or I switch straight away and start new in Madrid.
Or radiotherapy here and then the next component in Madrid, because that gives us about 10. We actually have about 3 months to get the chemotherapy set up in Madrid. But how we would do that at the moment, I have no idea, and so that would be a challenge for us both, but not impossible, because we do have some time. But yes, those are the 3 options, I think.
Okay, yeah.
Have a think.
I'll have a think with
Have a
myself,
think.
and then of course with my employer as well.
Yes.
Because it's all happening at the same time, you know, the outsourcing of the department, and
It's a tricky thing for
It's a
anyone
bit,
to have to go through. Let me just write this. Continue.
it's
writing
another
this
it's
down.
another benefit of Brexit, so to speak. They are all leaving now.
But Carl, you can have a think about it, and if you've got any more questions or if you've made a decision, just give me a call, or me or Ruth a call. Or
Thank
anything
you.
else.
I just want to avoid delaying anything, you know, with
If you can read my writing, that might be helpful.
I think I do. So first is CT scan and shell, 1 to 2 weeks. RT department, radiotherapy department. Second stage, 6 weeks, radiotherapy. Third stage, 4-week gap.
Yeah.
Fourth stage, 6 months chemo,
That's right.
pills.
Yeah. There's some information about the chemotherapy pills. I think Katie's got some other information for you as well about the radiotherapy.
Okay, what about, because right now I'm fine physically, but I guess discomfort or pain may kick in any time. So can I I mean, beyond paracetamol and over-the-counter things, how can I get access to painkillers and
So normally dexamethasone is the best thing to use actually. So if you're talking about headache,
but that's steroids, right?
yes,
Yeah,
that's
that
steroids.
helps.
That's the most effective treatment for headaches from a brain tumour, because it's normally the swelling that's causing the headache.
Because in the ward, I got some of where are they? Some of these, which I know are addictive, but I would only take them as needed, and I don't have them anymore.
Yeah, well, I wouldn't recommend you use those. I don't think we'll need
No.
them.
That would have just been for post-op,
Yeah,
for just
Oh.
immediate pain after you've had your surgery.
exactly.
We don't. It's very rare that we have to find additional painkillers for patients. It's
So the dexamethasone
yeah,
does
because
the job.
Pain is from swelling, and the steroids are brilliant at reducing that swelling.
Right.
So although it's not a painkiller, it does a great job as well.
So even though I have been on a very, very rigid withdrawal plan, is the dexamethasone something that can be taken as needed?
No. But let's talk about
Yeah.
the dexamethasone.
Okay.
So you're taking 0.5 milligrams at the moment, is that right?
Yeah, stopping tomorrow.
And since you've been reducing the steroid, the seizures have been getting worse, is that right?
More frequent.
More frequent.
Not worse.
I understand. But you're not having any headaches or anything
No.
else? Okay.
But I have been taking paracetamol on a permanent basis.
Okay. Why don't we go back up to 2 milligrams of dexamethasone and see if
Right.
that makes things better.
Okay.
And in the meantime, we will talk to our neurologist colleague to get some advice about what to do about the seizures themselves.
Right. Okay.
I think let's just, if our rule is we always want people on the lowest dose of steroid that they need, but if by reducing them things are getting worse, it suggests that we're coming down too quickly.
Well, worse. It's different. They used to be
longer.
very long,
Mm.
more violent,
Mm.
but not so frequent. Now I get 3 or 4 a day that last 1 minute, and so it's manageable.
Yes.
I don't maybe because I don't want to waste capacity. You know, if I need them later, I'd rather wait. Because right now I'm not in an unbearable pain or so. So I'm not so sure about the swelling, but if dexamethasone is really that good, we might as well.
But 2 milligrams is a smidge of a dose. We have people on 16 milligrams.
Oh, okay,
So we've
didn't
got
know that.
plenty
Oh,
more to
right.
do.
Oh,
Yeah.
right. Okay. In
I
that case,
I suggest just for another week or so, let's
Yeah.
keep you on the 2 milligrams.
okay.
Just as a holding measure. Let's get you on an additional anticonvulsants, and once that's been started, let's reduce down again. That's my suggestion.
Good. I'll do whatever you say.
Okay, sorry. I think you wanted to ask questions earlier, and I didn't
Could-
give you a chance because I wanted to finish my
I'll translate because we speak Spanish.
Sure.
Me gustaría saber si el 1% que tú tienes de posibilidad de alargar tu vida, isso pode ser anos, décadas.
Oh, the slight chance, like 1% of a very long lifespan or life expectancy. How long is that likely or possible to be? Is that a decade or?
No, let's not talk about complete hypotheticals. If the final histology does show something unexpected, I will let you know. But I don't want to get into all sorts of what ifs because I don't think that's helpful.
No, but with the information we have now,
We think.
and assuming that the final result will not vary,
I see. Sorry. Yes.
in that case, that slight chance of a longer.
Oh, sorry. I misunderstood. Yes. Well, it's
How
up-
long would that be? Could that be a decade, or would that be just 5 years? Is that your point? Yeah.
Yeah. I don't have a good answer to that question. So
You don't?
I don't have a good answer.
He doesn't know.
Okay.
Yeah. A small number of patients do extremely well, and we do see some who live 10 years or more. But that's
individually.
That's rare.
That's rare.
Yeah.
Like 1 in 1,000.
Well, to be perfectly honest with you, it's more than that. If you look at the studies, and especially the original study, up to 5-10% of patients do significantly better. Our feeling now is that there's a possibility that those older trials, the patients might have been misdiagnosed.
Oh,
But we don't know.
yeah.
So there's lots of uncertainty. So there's always going to be uncertainty. We're
Okay.
always dealing in probabilities,
Yeah. I understand.
and we always hope that you'll do much better than the
Yeah.
average.
Of course.
But we can't really say much more than that with certainty.
Okay. Thank you very much for your openness and frankness. And I like. Well, you may have noticed I'm German, and I like matter of fact things and you know,
Yeah, so do we.
certainty
That's
rather
yeah,
than hope.
Yeah, we can't give you certainty, but we can.
No.
But we
I
can
mean-
give you facts, and we can,
You know, not certainty, but facts rather than hope. Yeah.
Yeah, there is hope. There is hope, but what
Also, what is hope?
Well, exactly.
You know,
exactly.
hope of.
It means different
of
things to different people.
Yeah, exactly. Well, I guess you've had this conversation like 1,000 times.
More than I'd have liked. Yes.
So that's a lot to take in. I will think a lot and stay in touch with you. Or
Yeah, absolutely.
so what is the immediate next thing you need me to do? What's my
You need to tell
action needed?
do you want treatment and where do you want treatment? And as soon as you say, if you say, yes, you want it and you want it here, I'll pull the trigger and get things started.
And you did say one part of the treatment can start immediately without being disruptive of a change later. Yeah?
Yes, as I said, I think one possibility, although logistically it will be a challenge, would be to give you the radiotherapy here and the chemotherapy in Madrid, the 6 months of treatment afterwards.
Yeah.
What I would like to do, if it's okay with you, is get a signature from you now.
Yeah, well, I can try.
You can use your good hand. Completely non-binding.
Right.
But this way, if you suddenly call, especially as I'm at a conference later this week, and I won't be able to see you on very short notice, if you suddenly call and say that you do want the treatment, I've got enough to get things started.
Let's do that. Do you understand? I can still... Todavía me puedo decidir, pero como él va a estar fuera, y si le dejo firmado una cosita, y yo puedo decirles en el momento que me decida que quiero hacer una parte del tratamiento aquí, entonces él ya puede iniciar las cosas sin perder fechas con esa firma. En cambio, si no lo dejo firmado, pues lo demoraríamos. Pero eso ya se lo puedo dejar firmado incluso con la mano mala. Let's do that, yes, absolutely.
Thank you.
And this would be in that center opposite? Or?
No, the radiotherapy is in this building.
Right.
And the chemotherapy component, once you're just on chemotherapy alone, you can actually even get those from Hayward Heath.
Oh.
But the radiotherapy can't be done in Hayward Heath. That can only be done here, I'm afraid.
And that would be usually in the mornings or?
Well, remember, it's tablets.
No, the radio.
Oh, the radiotherapy.
Sure, sorry.
No, all day.
All day?
No, it takes 10,
Oh.
15 minutes, but the machines run all
Right,
day.
okay. So it could be in the morning?
Could be in the
From
morning.
9 or?
Yes, could be later in the day. Are there any times that are less good for you?
Well, I'll look for the best ones. I mean...
So the treatment, each fraction of radiotherapy actually only takes about 10 minutes, but there can be
Brilliant.
waiting. So we say allow an hour.
Okay. Yeah.
If you sign there, please, that's just for the chemotherapy.
Should I try with my old good hand
It's
or?
completely up to you. Whatever you consider to be your current signature.
I don't even know.
It doesn't matter.
Well, I'll give it a go.
It's better than mine anyway.
Wow, that's actually quite accurate.
That is impressive.
So 22. No.
It's the 20th, yeah, the 6th, 22. Brilliant.
Name print. Carl.
Yep.
Michael. SCHUT.
Great.
Thank you very much, and nice to meet you.
And you kindly photocopy that for you, so you've got a copy as well. That's for you. Sorry, that's for you.
Absolutely.
All right.
So regarding meds,
So
should I?
increase the dexamethasone to 2 milligrams.
Who gives me the actual pills?
Have you run out?
I've got half for tomorrow, and that's it.
Okay. Let me think.
I've got lots of Keppra.
Yep, but you need some more dexamethasone. I can give you a prescription to take to your local pharmacy.
Yeah,
Yep.
Absolutely. Bueno.
Me gustaría no hablar nada, pero cuando esté en tu piso,
Vale,
hablamos.
vale, vale.
Right, that's your copy.
Thank you very much.
Have we done your height and weight recently?
Yes, today. So my go-to person is now you, basically not Ruth.
We both do the same job,
Right.
so
Okay.
either of us. The number, the 01444 number comes, the voice messages come through to both of us and the emails come through to both of us.
And at some point, I think I saw a 077 number on the internet. I'm not sure if that's something I should be using.
So Ruth has a mobile number, I don't.
Okay.
It's safer to use the 01444.
So you do get like a copy on your voice box if ever.
Absolutely, for the emails. So when you leave a voicemail on the 01444, I get an email and I can listen to your voice message through the emails.
Brilliant.
So the mobiles, the Ruth's mobile I say is less safe just because, for example, if she goes on annual leave, I
Yeah.
don't mind her phone.
Oh,
So
right.
it just won't get answered.
I
But the
understand.
01444 number, someone is monitoring it every day.
Okay.
So it's always safer just to go for that one.
So from tomorrow, start taking 2 milligrams again, right?
From today, if you want.
Okay. Well, I've taken half.
Just
Half
take
milligram.
1.5, yeah, take 1.5.
If you've got it. If you start tomorrow, that's also fine.
For the time being, or
Until, for the time being, I don't want you to be on that dose for a long time, but that's for another week at least.
and then what? After that week, my follow-up is with you regarding the prescriptions, or
Well,
with
then
my
should
GP.
Should we just stay on it for now because we want to speak to our neurologist
Oh.
and get advice about your seizure medication because it would be nice to get you settled on
Good.
something or started at least on something new before we do too much. with
Something
later.
new or additional?
So it will be as well as
Good.
the
Okay.
Keppra, yeah.
Yeah.
Certainly to begin with, we might pull back on the Keppra. If the new one works wonderfully, then we might pull back on the Keppra. But
Right.
just to start with, we won't touch a Keppra dose.
Okay. Good. Good.
Okay, and that is also for you.
Thank you very much. Right. Well, I don't want to look happy, but I'm not surprised. I mean, this is something I was. It was implied. It was a possibility, so that's fine. And I'm grateful for your clarity and for doing this job, which I'm sure is not easy.
Well, it's it's in a similar vein. I wish we weren't having this conversation, but it was nice to meet you both, and I'll catch up with you soon.
Thank you very much. Nice to meet you.
Thank you very much.
Bye bye.
If you think of any other questions or anything, just give me a call.
Thank you.
Right, speak to
Bye
you.
bye. Un segundo.